attention pour donc écouter notre expert du jour, le professeur Garillo. Merci. Vraiment bienvenue à tout le monde. Je vois qu'il y a beaucoup de personnes d'horizons divers, donc on va échanger après. Merci.
Okay, I will ask for our next slide, please. If we are going to talk briefly about syncope, the first point is a definition of syncope. As you can see, excusez-moi, as you can see, syncope, c'est une perte de conscience transitoire, apparition brutale, courte durée et récupération spontanée due à une hypoperfusion cérébrale. If you take a look of this definition, it's very interesting because in few cases in medicine, you have this kind of definition that shows you from one side the clinical situation, a sudden, short, and rapid recuperation. But on the other side, the definition offers you the physiopathology of the disease, that is the hyperperfusion cerebral. This is not very common in medicine, that we have both things, the clinical aspect and the physiopathology in one definition, and this is a very interesting case. Next one, please. When we are facing a syncope, we ask ourselves, which is the message of this syncope? Is it a friendly remark, reminder, warning, or on the contrary, it's a very serious warning about the risk in the near future? Or it could be worse, it's a threat of death. They are telling us that our patient is on risk of death. This is part of the message of the syncope, and we need to put black on white what is the message in each patient. Next, please. The other interesting point of the syncope is a dilemma. What means a dilemma? Or better, why is a dilemma? It's a dilemma because we are always talking about something that occurred in the past. If you have a patient with atrial fibrillation or a chest pain or premature ventricular contraction, you have someone that is suffering something that you can see immediately in a real time. But when we are talking with our patient about a syncope, we are talking about the past, something that has already occurred, and we don't know exactly how it was. And the other point associated with this dilemma is that although we can perform a lot of studies, we arrive to a probably cause of the syncope, but we didn't know exactly if that episode in the past was a real syncope and what happened at that time. We are just looking some proof and some suspicions about the motive, the subject of the syncope, but we don't know exactly what happened at that day. Next. Why it's necessary, it's imperative to know what happened in the past? It's very simple, because the first point is that we need to have a prognosis about the risk of our patient in the future. We need to know if our patient is on risk of dying in the near future. On the other hand, we need to know which was the cause to establish the right therapy for our patients. Next, please. Tracing loss of consciousness is the chapter where syncope is involved. And the first step is to put clear if that episode was related with a traumatic transient loss of consciousness or non-traumatic. We are looking in syncope, we are looking for a non-traumatic loss of consciousness. And if you are facing this non-traumatic, we have 4 possibilities: the syncope itself, the epilepsy episode, the psychogenic episode, or other causes that are more infrequent. If we are talking about syncope, we are talking about different forms of presentation that could be reflex or neuromedially episodes, cerebral episode, orthostatic or cardiac episode. One of the things that happen is sometimes we have doubts if our patients suffer a syncope or a crisis of epilepsy. But in the global population, how common is syncope and how common is epilepsy? Well, as you can see, the relation between syncope and epilepsy is 37-1. What it means that probably the most common reason before any analysis, the most common reason is syncope by far. Then this is the first step although we can analyze, and of course we can analyze all the material and perform all the study to establish exactly if it was a syncope and which kind of syncope to establish the right therapy. And in the world of syncope, in the chapter of syncope, we are talking about 3 different kinds of syncope: reflex, orthostatic, or cardiac. Next, please. Which are the forms of presentation of syncope? Next, please. Well, first of all, we have 3 kinds of syncope: reflex, orthostatic, and cardiogenic. Next, the reasons are always the same: low peripheral resistance, low cardiac output, and in some opportunities, both things could be present at the same time. If you are talking about reflex, if the predominant is vasodilation, there is a reflex, vasodilation reflex, or cardio inhibitor reflex, or sometimes both things are together. In the clinical, in this clinical case, or in our patient, this is a mixed form. It means that also occur that are present a low peripheral resistance and a low cardiac output. On the other side, if you are talking about cardiogenic syncope, we need to recognize that there are 3 main groups: those related with great vessels, those related with structural disease in the heart, like aortic stenosis, or myxome, a tumor in the left atrial, or the most common cause, cardiac arrhythmias, supraventricular or ventricular cardiac arrhythmias. And finally, if we move to the autonomic nervous system abnormality that cause the orthostatic syncope, there are 2 main groups: primary abnormal autonomic nervous system that can occur, for instance, very common associated with diabetes, or those related with our therapy, our own attitude, meaning that secondary abnormal autonomic nervous system disease that promote orthostatic syncope are related with drugs. That could be diuretics, beta blockers, antiarrhythmics, calcium blockers, and other drugs that can perform this kind of influence that at the end of the day provoke an orthostatic syncope. But all of these groups have the same physiopathology, that is cerebral hypoperfusion. Next one, please. When we are starting to analyze a patient with syncope, we must take into account the personal antecedents, familiar antecedents, the clinical condition, the episode of transient loss of consciousness, the physical examination, the control of the blood pressure that must be standing and in line down, and the electrocardiogram. But I prefer to move to the next slide, this one, because we need to organize an algorithm to control the study of syncope. This algorithm has the first step that are related with 5 points: antecedents, physical examination, electrocardiogram, laboratory, and echocardiogram. According to the results in the literature that we can read in any book or article, we will see that with these 5 elements, in 50% of the times, we will arrive to our diagnosis related to the cause of the syncope. In that case, as you can see on the left, if we confirm, we need to move to the next step, that is at the bottom, the therapy. But if not, we can have 2 possibilities: that we have a very high probability, but not confirmed, but high probability that could be cardiological or non-cardiological. If it's cardiological, the next step, as you can see, is an electrophysiological study. And if this study is positive, we need to move to the therapy. If not, we need to move to the right to the tilt test or implantable loop recorder. On the other side, if the high probability is related with non-cardiopathy, the next step will be the tilt test or the implantable loop recorder. Finally, if we, after the 5 points of the first step, we unknown the cause of the syncope, there are 2 considerations. The first one is, if that episode is rare or infrequent and benign, we need to stop our study. But if it's very frequent and severe each time, we need to move once again to the next step, that is tilt test and implantable loop recording. In this case, if it is positive, we, as you can see, move to the bottom to the therapy. And if not, we need to do the re-evaluation of the entire situation. Once again, we need to restart to study our patient. Next, please. This is our last slide before to move to our clinical cases. And this is related to a score of risk of death in the next 12 months or 1 year after the episode. There are many scores. You will find in the literature a lot of scores, but I elected this one. I have chosen this one because it's very simple. We can perform it in our office, and it's very interesting to have a prognosis about the risk of our patient. Is the OESIL, is an Italian risk score, and as you can read, there are 4 points: abnormal electrocardiogram, antecedents of cardiovascular disease, syncope without prodromes, or age over 65 years old. If our patient has any one of these 4, the risk of death for the next 12 months is very, very low. It's 0.8%. But if our patient has at least 2 of these 4, take a look, the number that now increased to 20% or around 20%, meaning that each 5 patients in that condition, 1 of them will die during this first year. But if the patient have 3 of these 4 risk factors, then you can see that the risk increased to around 35%, meaning that each 3 patients in that condition, 1 will die in the next 12 months. And at the end, if the patient has these 4 risk factors, take a look, that is over 50%, nearly 60%, meaning that for each 2 patients, at least 1 will die in the next 12 months. This is a very simple risk of score that led us to have an approach of the risk of death of our patient before any study, before any control, just with a conversation with our patient and with 1 or 2 information like the electrocardiogram, we can establish the risk of death. If this is clear, we can move to the 3 clinical cases that I have chosen for you, and we will develop this analysis in these 3 patients, and you will vote in during this presentation which could be your behavior, your conduct, or your study of reference that you will choose for each patient in each opportunity. Next one, please. Okay, as you can see, this first clinical case is related with an old lady, 81-year-old, with antecedent of high blood pressure for a long 30 years, and with a cardiac infarction 12 years before, and with up to that moment with a very good evolution, without symptoms, functional class 1, and only receiving a therapy for your circulation, cerebral circulation. Nothing very serious. But during the last 5 years, he suffered from episodes, time to time, episode of pre-syncope, near syncope, and in sometimes a real syncope. He went to the neurology, he received an electroencephalogram and a scanner, and all the studies were absolutely normal. And this is the electrocardiogram of this lady. As you can see, it's an electrocardiogram with some repolarization alteration and with a scar of infarction that include V1, V2, V3, and V4, in the anterior wall, and but once again, take into account that the patient was without symptom, except in the last 5 years episodes of pre-syncope or syncope. Next one, please. According our algorithm, we have the antecedents, we have the physical examination, we have the electrocardiogram, we have the echocardiogram that is here. You can see that is a mild aortic stenosis and regurgitation, hypertrophic of the left ventricle, mild once again, some dilation of the left atrial, some hypokinesis or mild hypokinesis apical, but with a ventricular ejection fraction normal, around 50%. She performed a Holter study that was negative. During the night, the heart rate arrived to 42. During the day, arrived to 112. The average was 55 beats per minute without pauses and with some premature ventricular contraction, ventricular and supraventricular. Next one. Okay. We have the antecedents, we have the physical examination, the electrocardiogram, the laboratory, the echo, everything was normal. But because the antecedents, I guess, and probably you agree with me, the patient have high probability that the cause of the syncope is related with something associated with the heart. Probably is a cardiac syncope. Then, could we move to the next, please? Okay. No. Okay, that was the next. Okay. Okay, show me. The electrophysiological study was normal, AH 90, HV 36. The point of Benkeba was 115. The carotid sinus massage was negative, and the stimulation, the ventricular stimulation looking for ventricular tachycardia also was negative. The tilt test was negative in conventional mode, and adding isoproterenol in both cases was absolutely normal. We need to move to the next slide, please. Okay, this is time for you, not for me. All of you, we are around 87. Yeah. Okay, there are many people, and then you need to take the decision what we have to do with this patient to try to solve the problem of the syncope, which was the cause. You have the possibilities, and you have 20 seconds, 1 minute to vote, which should be our next step.
Okay, vous pouvez voter directement.
Yeah, you are voting. I can see.
Yeah.
Okay. Okay.
Very good. We have about half have vote now.
There are many people that didn't vote yet. Okay, I want to know the opinion of all of you, not about someone of you. All of you. I need all the opinions. We are 31, 35, 44,
Le vote est
44.
anonyme.
Ouais, n'ayez pas peur.
What happened with the rest of the people? Where are you, my friends? 89. Where are the 89? The reminder people, where are they?
Plus
I
que
want to
40
hear-
secondes pour voter.
There are shy people. Are there shy people in Africa? I can't believe it. No, it's not true. No, it's not true. It's not true. Anyone is anonymous. Nobody
Yeah,
knows.
it is anonymous.
Yeah, tell me. Give me your opinion. 31, 12, 4, 2. Okay. Okay. Which is the time? Well, we are on time. We will stop here the voting.
Yes.
Yeah? Okay. Okay. Let me analyze with all of you. Most of you, 62%, recommend an implantable loop recorder. 24% of you recommend to repeat with more halter. Maybe, I guess, you are the owner of the halters and you are trying to make more money. I don't know. I will see. Some of you, 8% of you recommend directly to move to a pacemaker. And 6% of you recommend an implantable defibrillator. Well, all these opinions are interesting, all have value. And now I will let you know which was our decision, what we have done. Okay? Could we move to the next slide, please?
Sonia, tu peux arrêter le partage.
Okay, we decided to implant an implantable loop recording. Like, could you put out this the voting result, please?
I don't understand.
I did it. Okay, most of you recommend the implantable loop recorder. Take a look what happened. After 67 days, the patient presented an episode of pre-syncope with 3 seconds of pause. You could see here in the second and in the third line, after a tachy episode. It's a tachybrady syndrome with a pause that promote a pre-syncope. But move to the next, please. After 85 days, the patient present a syncope, a real syncope, and a pause of 6 seconds, as you can see in the second and in the third line, and before a tachy episode. Once again, tachybrady syndrome with a prolonged pause that was the cause of the syncope. The comment is, most of you were right, thinking 2/3 of you recommend an implantable loop recorded, and you are right, because take a look about the halter. It's impossible to perform 85 days of halter continuously to obtain this image. You need a device that you can implant. And each kind of devices have a duration of 3 years. You have a lot of time to discover what was happening with the lady. Some of you, 6% of you recommend a defibrillator. As you can see, this was not the case because the patients didn't suffer of ventricular tachycardia or ventricular fibrillation. They suffer from asystole. Then the recommendation is a pacemaker. And that was we have done. Next, please. We decided to implant a pacemaker because the asystole was the cause of the syncope. Now, I want to ask all of you, please, which kind of pacemaker would you recommend for this lady? A VVI with rate response, a DDD, or a DDDR, once again with rate response. I'm ready to see which is your comment, your recommendation. I'm ready, and I expect that all of you, now around 92, will tell me what I have to do with my patients. Help me with my patient, please. I need help. Don't be shy. The vote of all of you, that's what I want to see. 10.
Allez les gars. C'est trop lent. Donc, syncope sur maladie de l'oreille, pratiquement. Donc, qu'est-ce que vous choisissez?
On n'arrive pas à soumettre. Hein?
Ah bon? Pourtant, il y a des soumissions en ligne. Hein. On voit qu'il y a des gens qui soumettent. Je sais pas.
Bonsoir, prof.
Bonsoir.
Au fait, il y a une seconde question sur les possibilités de réponse et il faut cocher aussi les réponses pour la seconde question.
Oui, il y a un deuxième truc à choisir, ouais. C'est bizarre.
Oui.
Il faut faire next et puis choisir quelque chose.
Ah oui, ça, Sonia, peut-être, elle vous entend, c'est elle qui administre. Sonia, tu as entendu le problème? Bon, peut-être,
oui,
je ne sais pas si tu as compris.
J'ai vu, mais je ne pense pas que j'ai la possibilité de modifier celui-là.
D'accord, bon, on va avancer après. On va essayer de rectifier sur les autres.
Si c'est modifiable, il faut cocher la deuxième.
Cocher la deuxième.
Oui, il y a des...
So, comment il s'appelle? Pharmacien, tu m'entends?
Parce que docteur Traoré, en
C'est
fait,
dans la conception.
Oui.
C'est dans la conception, en fait.
Oui.
Donc, là, comme j'ai déjà lancé le vote, je ne peux pas le modifier. Il faut que j'arrête le
Oui,
vote.
je voulais dire en bon anglais que on est en train de truquer les votes comme ça se passe très souvent en Afrique. Je ne sais pas comment tu peux expliquer ça.
So we are rigging the vote.
Elle n'a pas dit, hein?
We are rigging the vote.
Okay.
Yeah, Raul, the vote is going to be rigged because as it happened in Africa, this is the way we manage things.
Yeah.
I understand. I see. Well, we will stop in 5 or 6 seconds. It's enough, 3 minutes to take the decision.
Okay.
Come on. This is the final results. Okay. As you can see, most of you have chosen DDD. That could be correct. 28% of you decided for DDDR, PVVR 26, and 9% those who have chosen VVI. Comments. First of all, nowadays, I know that there are economical reasons in any part of the world and in Argentina, of course, too. But our decision is a medical decision. After that, if we cannot get the pacemaker that we need, we can accept other. But from the very beginning, we need to ask for the pacemaker that we believe that is necessary. And if we can get it, okay, will be other. But from the very beginning, which is our recommendation? Let me tell you that VV or VVR is recommended only for people with chronic or permanent atrial fibrillation. This is the nowadays for all the world the indication for VVI or VVIR, right? Then from the beginning for our patient, the pacemaker should be a dual chamber. a dual chamber with rate responsive or not? This is the second question. This patient, of course, are suffering of a sick sinus syndrome with episode of tachybrady. That is the way of some way of presentation of the sick sinus syndrome. Then, as she has episode of bradycardia, also she has episode of tachycardia. Then for this patient, the indication should be a DDDR with rate responsive. All sick sinus syndrome deserve a rate response, dual chamber and rate response. And that was we have finally implanted in this lady. Okay.
If you want, Raul, I'm gonna translate. It is very important.
Yes, of course.
It is a point.
Please,
very important.
Yes.
So, en fait, ce qui se passe, c'est que cette dame fait une maladie de l'oreille. Donc, il y a des épisodes de tachycardie et de bradycardie. Parfois, elle est en fibrillation atriale. Donc, ça veut dire que son nœud sinusal n'est probablement pas sain. Donc, c'est une maladie de l'oreille. Donc, c'est ce qu'on appelait avant même le sick sinus syndrome. Et donc, il peut avoir besoin d'être accéléré. Donc, il peut avoir des problèmes lorsqu'elle aura besoin d'être accélérée. Parce que le nœud sinusal, je le rappelle, c'est l'asservisseur naturel. Donc, c'est pour cela, pour lui mettre un pacemaker adéquat, il faut mettre un pacemaker qui a la possibilité d'un asservissement. L'asservissement, c'est l'accélération lorsque la personne est en train de faire un effort. Donc, c'était un peu ça. Et puis, je pense que je vais le laisser passer. De toute façon, après, on aura le temps de répondre aux questions. Merci. Thank you.
Okay.
You can go on.
Okay, we can move to our next clinical case. The second clinical case. It's a man, 61 years old. Before the admission at the hospital, he was, during the 2 weeks before, he was tired, adynamic, and with a heart rate around 40 beats per minute, a very low heart rate. In the morning of the admission at the hospital, he presented an episode of syncope without prodromes and with a traumatism because he fall down and he have a traumatism in his face. Next one, which is the antecedent. He has a high blood pressure. He has a diabetes type 2, obesity, and is sedentary. Also, he has a diagnosis of hyperalteronismus primary hyperalteronism, and he received a medication, is aldactone, to save potassium, 50 milligrams per day. That was the only medication. In the examination, he was normal, he was lucid, he was oriented in the time and in the space. He has no focus, motor focus or sensitive. He has no heart failure. He has no murmur in the heart. And he has a good perfusion, good peripheral perfusion. And at that time, the blood pressure was 170/90. And once again, the heart rate was 40 per minute. Next, please. This was the electrocardiogram. Take a look that you can see a P wave. Then our first impression is that it's a sinus rhythm. It's a sinus rhythm, but with a block, AB block 221. There are 2 P waves for each QRS, and the QRS is a white QRS telling us that he has some kind of disturbance in the interventricular conduction, and in fact, he has a pattern of right bundle branch block. Clearly, you can see in V1, R, S, and a second R, taller. And this is a pattern, it's a clinical pattern of right bundle branch block. And secondary changes in the repolarization, but due to the right bundle branch block. Next, please. The laboratory was normal except for the potassium that was low, as you can see, and also for the sodium that was low, but mainly the potassium was really low. Next, please. Okay, this is time for questions. What happened with my patient with 40 beats per minute and with a syncope episode? It was a bradyarrhythmic syncope. It was a paroxystic atrial fibrillation. He suffered a complete epiblock or a ventricular tachycardia or a torsa d'appoint, that is a kind of ventricular tachycardia. Which is your impression? I'm ready to read your opinion.
Alors, Sonia, le problème du vote est réglé ou pas?
Okay, okay. I'm seeing a lot of opinions. No?
No,
Wow.
bien.
Okay, okay, okay.
Bon.
Doesn't matter. Okay, we have enough opinion. Most of you, the opinion from most of you was related to bradyarrhythmia, 53%. Another group thinks that as this patient has a AB block 221, maybe the episode was related with a complete AB block, what is reasonable, 34%. 13%, the opinion was a torsa d'appoint. And as you can see, maybe right now, or you have already seen, next please.
Arrêtez le partage.
Next slide. Well, this is what the telemetry, while he was at the hospital, we can record. And clearly is a torsa d'appoint. And you can see as it's an helix, it's moving the QRS from up to down, and it's a typical torsa d'appoint. Take a look that it has a prolonged QT interval. That is really, it's very common in patients with hypokalemia. That was the reason. The hypokalemia, also with hypomagnesemia, promote this kind of QRS, and that could be trigger a ventricular tachycardia, that particular tachycardia that is torsa d'appoint. Next, please. Okay, then now we have a diagnosis. Now we know which was the reason because our patient lost his consciousness. It's a syncope due a tachycardia, a ventricular tachycardia, the kind of torsa d'appoint related with hypokalemia and also bradycardia. There are two reasons, plus magnesemia, that help to all promote, not help, but promote the development of this kind of ventricular tachycardia. Next slide, please. Then, now is my question for all of you. You are 89, and I expect to receive 89 different opinions, please. We need to implant a transitory pacemaker, improve the condition of potassium and magnesium, and after that to implant a DDDR. We need to put a defibrillator directly because we prove a ventricular tachycardia, or is enough to replace potassium and magnesium, and when they arrive to a normal value, that's it. We don't need neither a pacemaker nor a defibrillator. Which is your opinion? I'm ready to read I'm eager to read your opinion, and I expect that no one will be shy in this opportunity, this time. Everybody will give me the opinion, your opinion. Well, I can see that the opinion is diverse. Three different and important opinions. Okay. 22, 20, and 10. But 20 and 22, they are very, very similar, these two groups of opinions. Okay. But only 50% of the people, around 55% of the people gave me their opinion. What's going on with the rest of you? I'm ready to hear all of you. This is a democratic session. All of you can give your opinion.
Exactly.
Come on. Okay. Okay. Okay, we need to stop because there are no more opinions. All right, let me see. Take a look about your opinion, most of you. 43% are suggesting that is maybe the best therapy is to replace potassium and magnesium, and that's it. That could be. The other group, 38%, their opinion is in the meantime, a transitory pacemaker, normalize potassium and magnesium, and finally implant a dual chamber pacemaker. And a small group, 20%, not so small, but a group of 20% suggest a defibrillator. My first comment is that to replace potassium and magnesium is a right therapy. But with this patient, with this risk, it's impossible to know if in 2 or 3 months, once again, he will suffer an imbalance of potassium and magnesium. It's difficult to control the value of potassium and magnesium in the blood. Then it's not enough to replace. It's necessary, but it's not enough. To put the defibrillator, the arrhythmia was related clearly with bradycardia and with low potassium. Then, if I replace or if I put an adequate level of potassium and magnesium, is the first step. But I need to control the bradycardia because the bradycardia promote with the low potassium promote the top point. Then I need a pacemaker to control the bradycardia, and of course control the level of potassium and magnesium. Then is that we have done. Put an implantable pacemaker, DDDR, with a strict control of potassium and magnesium. Under that condition, the defibrillator is not necessary. And this is very important in terms of cost and quality of life. Okay? Well, we
so
move
Raul,
to
here you suggest the answer 1 and 3.
No, I suggest
or just
one.
Only one. Okay.
It's not enough to add potassium and magnesium, because any imbalance can occur in any moment, and in the under the bradycardia associated with this imbalance, the toxa de Pointes could be appear again, and instead of syncope could be a sudden death. We need to avoid this situation. Okay.
Yeah.
Do you want to comment in French?
En fait, je pense que c'est clair. C'est-à-dire qu'il préconise la réponse numéro 1, puisqu'il faudrait mettre un stimulateur cardiaque transitoire avec remplacement du potassium et du magnésium. Puisque si on met juste magnésium et potassium, si on fait donc le remplacement, si on charge en potassium, en magnésium pour restaurer l'ionogramme, un ionogramme normal sans mettre une fréquence cardiaque acceptable, le fait qu'il y ait une bradycardie en attendant de corriger donc le désordre ionique peut entraîner donc des récidives de torsade de pointe. Donc ainsi, c'est la première option qui est retenue, c'est-à-dire mettre un pacemaker temporaire et corriger donc les désordres ioniques et après voir ce qui se passe. Donc normalement, si c'était un bloc auriculo-ventriculaire secondaire à ces troubles ioniques-là, tout devait rentrer dans l'ombre. Voilà. Thank you. I think you can go on.
Okay, we move to our last presentation. Okay, this is, excuse me, go back, please. This is what we have done. We put a transitory pacemaker to control the bradycardia. We add potassium and magnesium, and at the end, we implant definitely a permanent pacemaker, a DDDR pacemaker. That is what we have done. Thank you. Now we can move to our last clinical case. Yeah.
I have a comment, another comment, because you know we had a patient like yours, but we had a problem to have a good thresholds for simulation, because the thresholds of simulation was very high, and we had the good position, an anatomical position, but we couldn't capture the ventricle due to the problem of kaliemia. I don't know if you had this when you did this.
Sometime, not in this case.
I'm gonna translate.
Please.
I'm gonna translate if you permit. Donc,
of course.
Ma question c'était que ces genres de patients qui ont une dyskaliémie, ils peuvent avoir un CI très élevé, c'est-à-dire on peut avoir une bonne position anatomique, mais en réalité, on peut ne pas capturer le ventricule parce que s'il y a une dyskaliémie, le CI de stimulation peut être très élevé. Donc, on peut avoir ce genre de problème-là. Si après une bonne position anatomique, on n'arrive pas à capturer le ventricule, il faut peut-être incriminer le désordre ionique. Voilà. Thank you.
Okay, we can move to our last clinical case. Once again, it's a man, 44 years old, with a normal body mass index, no smoker, with very good physical activity, football twice per week, without antecedents of medical disease, without antecedents in the familia of syncope, and he's not receiving therapy, any kind of therapy. He's not receiving medication he don't need medication. He was a normal guy, performing his physical activity. Everything was going well. Next, please. But he arrived to the emergency room at the hospital because of syncope of unknown cause. He referred nausea and blurred vision before loss of consciousness while he was sitting in his house watching TV. At the moment of the admission, the blood pressure was 105/60, and the heart rate was 67. It was his first episode. Next, please. The physical examination was normal. The laboratory was normal. The echocardiogram was normal. Next, please. And this was the electrocardiogram with a normal axis, sinus rhythm, and with a heart rate is around 80 beats per minute. No repolarization alterations. Next one. Up to now, with this antecedents or without antecedent, in his early 40s, while he was watching TV, which is your presumptive diagnostic? Is a reflex syncope, neuromediated or reflex? It was a cardiogenic syncope because sinus node dysfunction, or is a cardiogenic syncope due to ventricular tachycardia? Okay, we are ready to vote. Come on. You are right now 89, and I expect to see 89 opinions. Come on, don't be shy. I need more opinions. Up to now, we have 47, and you are 89, 88. Someone left. Ooh. Only 40? 48. Come on. What happened with the rest? I need more opinions. I'm eager to see more opinions.
Yes, don't be shy, don't be shy.
Don't be shy. Okay. When we arrive to 2 minutes, we will stop. Okay. 50% of you, their opinion was a reflex syncope. Sinus node dysfunction, 15%. And ventricular tachycardia, 35%. Interesting, but we are just beginning with this patient. Well, keep this opinion in mind. I will keep it, and we move to next slide, please. What we should do right now, according to your opinion, we need to perform an electrophysiology study. We need to perform a tilt test. We need to perform an implantable loop recorder, or there is another study that you would like to perform. Give me your opinion, please. I can see the results. Could you put me on the screen the results, please?
Oui, on ne voit pas le vote. Hein. Sonia, tu as des difficultés pour mettre le voting system?
Moi, je vois le vote.
On voit le vote? Moi, je le vois. Prof ne le voit pas.
D'accord, donc c'est peut-être moi.
OK, parce que là, il n'est pas encore clôturé, donc...
Okay, I can see.
Okay.
I can see. I found it. Oh, I see. Well, still we have time that for more opinions. Up to now, most of you are voting for the tilt test. Some of you for implantable loop recorder. 17 electrophysiological study, 70%. Some of you suggest other kind of a study. I don't know which one. Okay. Oh, we will stop in 10 seconds. Come on, move on. Give me your opinion, please. Okay, we are right. Most of you suggest tilt test, 55%. Some of you electrophysiological study, some of you implantable loop recorder, and some of you, one, suggest other kind of a study. It's a pity we don't know, we don't know which one. Okay. Could we move to our next slide, please? Okay, I will tell you what we have done. An electrophysiological study. We can develop ventricular tachycardia, and all the things that we found is a low point of Benkeback, 100 beats per minute, and recovery sinus node time corrected 850 milliseconds. Normal is up to 500. It's a delay. And this is the only thing that was wrong in the study. The rest of the study was absolutely normal. Next slide, please.
Can I translate, please,
Okay.
here?
Yeah, okay.
Because it is important. Alors,
Yeah.
ce qu'il a trouvé, ils ont fait, eux, une étude électrophysiologique. Et ce qu'ils ont trouvé, c'est une dysfonction sinusale avec un point de Wenckebach qui est à 100 battements par minute et puis un temps de récupération sinusale corrigé à 850 millisecondes. Donc ça traduit une dysfonction sinusale. Voilà.
According to this, back, please, back. The previous one.
Sonia,
yeah, that's okay, stop. According to this study, as you can see, it's a recommendation for a pacemaker if we find a patient with syncope of unexplained origin, when we found some alteration in the sinus node function. Sinus node function with alteration is a recommendation for a pacemaker. But keep in mind that the only thing that we found during the stimulation was a mild delay in the recovery time, was the only thing that was wrong. Is it very serious? is enough for a pacemaker implantation? We will see. Now, we need to move to the next slide, please. As you also recommended, tilt test, we have done a tilt test. And let me show you what we have found in the tilt test. We know that it's a drop in the blood pressure, and it's a drop in the rate of the sinus rhythm. We can consider this a mixed reflex syncope because it's due to low peripheral impedance with low blood pressure, with drop of the blood pressure, and it is a cardio inhibitor because we have a serious bradycardia for 5 or 6 seconds due to the tilt test done. The diagnostic for us was reflex syncope. We need to move to the next. Well, according to these two studies that you recommended, not me, you recommended, it's a recommendation that arrived to my hospital directly from Africa. And now I have this recommendation of you. It's not my responsibility, it's your responsibility. Which is the next step according to these results? Implant a pacemaker, TDDR, with possibilities to control the rate drop response, with rate drop response to block the bradycardia, a DDDR only without rate drop response because I believe that bradycardia is the main cause of the syncope, or we still need more studies, more other studies to have a final diagnosis. This is my question. What do you think? Is enough? And we suggest 1 or 2 possibilities, or we need to perform more studies.
Le sondage, Sonia?
Excusez-moi?
On peut mettre le sondage, oui.
Ah, okay. Okay, we still have time. I need more people voting, please. You are right now 84, and you have only 37 opinions. I need more opinions coming from you, please. Remember that is your responsibility because you suggest that study. Those studies were suggested by you, and I did it. Now that I have the results, I need your opinion what I have to do. $24. Okay, we will stop in 20 seconds. I still waiting for more opinions. Because this is part of this exercise, to share opinions among all of us to improve our knowledge, to be smarter. Okay, we are on time. We will see now that 50% of you, 51% of you suggest a pacemaker because the sinus node dysfunction. But my question is, it means that what happened with the tilt test, it doesn't matter? That the reflex syncope is not very important? And more, even more, that is not the cause of the syncope. Then the syncope is due to that bradycardia, could be. The second group, 30%, the opinion is DDDR, and they are thinking that the reflex is the cause of the syncope, and that is the reason because we need a pacemaker with possibility of have a mechanism for the rate drop response to control the low pressure. Okay. And nearly 20%, the opinion was we need to perform more studies. That is interesting. There are many opinions, many groups, and all of them have a little part of the truth. We need to move ahead, please. Next slide. Okay. The opinion of our group was related with this 19%. The smallest group of people that opinion that we need to perform more study. Why? Take a second look of this electrocardiogram. The second look of this electrocardiogram shows us once again sinus rhythm with some alteration in the repolarization, nothing very serious. But now take a look very carefully, V1 and V2. If you take a look of V1 and V2, precordial V1 and V2, you will see two things. First of all, look like if could be
Sonia, tu peux montrer hein, si tu...
incomplete right bundle branch block. Yeah, could be here and could be in V2, please. In V2 also. But it's not the image, the classic image of incomplete right bundle branch block. This is something that suggests that could be other thing. And this other thing could be related with a congenital syndrome, related with alteration in the electrical condition of the heart. Could we move to the next slide, please? We need to perform a test with a drug that is an asthmaline drug. The asthmaline drug promotes some changes in the electrocardiogram of patient who has a Brugada syndrome. This kind of patient, when you put some drug that block the sodium channel, we can exaggerate the electrocardiogram. Take a look carefully once again, V1 and V2 in the first minute after the drug. Nothing changed so much. Next, please. Next slide. In the third minute, it's a little bit difference overall in V1. And now move to the next slide.
Wow.
You can see that change completely in V1 and V2. And it's a classical image of the Brugada syndrome. Now, we discover that this patient has a Brugada syndrome, and Brugada syndrome is very close related with syncope, but also with sudden cardiac death. Now, we have an diagnostic Brugada syndrome. Next slide, please. Now that we know that it's a Brugada syndrome, and you know that Brugada syndrome promotes torsade point. Tell me what I have to do. Perform electrophysiological study to confirm the Brugada syndrome. Directly implant a cardioverter defibrillator, or treat the Brugada syndrome with antiarrhythmic drugs, or very simple, to control of the patient without therapy. What I have to do now that I know that the syncope probably was related to the Brugada syndrome. We are finishing, then I need your support and I need your voting. Your votes is very important.
Il faut bien finir. Hein. Ouais, il faut bien finir. Il faut que tout le monde vote là. Hein. Allez au vote, tout le monde. But Raul, in my opinion, the first image of before the Ajmalin test, it was a clearly show a Brugada syndrome type 1, I think. And if you are doubt, you don't put the lead little more up.
Yeah.
V1 little more up to see.
Instead of the 4 space, you can put it in the second space, in the right and in the left. Yes, of course. That is recommended. Yes, of course. It can help. It's a good idea. Yeah, I agree completely.
Because we have not Ajmalin here in Senegal.
Well, you can use flecainide, for instance. You have flecainide?
Peros, no intravenous, but in Peros.
Okay.
Yeah, oral.
Yeah, I understand. Any sodium blocker could work. Any sodium blocker. Ajmalin is more sensitive, but any sodium blocker could work. And the other advantage of Ajmalin, the effect is very, very short. It's just to prove that you have a Brugada, and that's it. Okay, we are in the second. 71%, the opinion it was a defibrillator. 9% the opinion was electrophysiological study. 16% is only with drugs, and 4% is with only control without drugs. Let me make a comment. Control without drugs after a syncope in a Brugada syndrome is not very recommended, except for your mother-in-law. That could be. If it's for your mother-in-law, yeah, I agree. But if not, it's not recommended at all. You can't do that. Okay? Move to the second. Electrophysiological study. Could be. But the Ajmalin test was very clear to show us something that we have suspicion with the normal electrocardiogram. Then you can do that, but it's not necessary. Drugs. Yes, we recommend drugs before any episode of syncope. But if the patient have already suffered a syncope, of course, you need to move to the defibrillator. Next slide, please. That I believe that is the last one. Okay, we perform an implantation, and during the implantation, we promote some induction of the ventricular tachycardia. And as you can see, after the stimuli, we develop a torsade point that is typical for Brugada syndrome. Then it was the right decision to implant a defibrillator. After a couple of years, this patient is okay, is good. He suffered only 1 episode of ventricular tachycardia that was blocked by the defibrillator. And let me, final comments. If you receive a man in the around 40 or in the earliest 40 with the first episode of syncope without antecedents, no personal, no familiar. This man, the first suspicion with a normal echocardiogram, with a normal physical examination, our first suspicion is Brugada syndrome. Sometimes could be hidden. You cannot see, but it's there. And you need to promote or higher precordial leads, as Adama recommended, or Achmalin test, but be sure that the first possibility, statistically speaking, is Brugada syndrome. Then each time that you receive a patient, and he was in repose, and he was at night, because Brugada syndrome is very similar to long QT syndrome type 3 that appear in repose, most of the time at night, when he was watching TV, doing nothing. He was not performing exercise, nothing. He was just watching TV. Then all these elements should push in our mind the idea that we are facing a Brugada syndrome. Okay?
Okay, very, very important the message. I can't translate because it is an important message.
Please.
So, en fait, ce qu'il dit, c'est lorsqu'on a un sujet jeune qui a un cœur normal et qui fait une syncope pour la première fois dans un contexte surtout de repos ou dans un contexte vagal, le premier diagnostic qu'il faudra éliminer, c'est un syndrome de Brugada. En faisant un bon électrocardiogramme, si on n'a pas de signes caractéristiques, on peut faire monter l'électrode V1 un peu au-dessus pour démasquer un Brugada qui est caché, ou bien faire un test à l'Ashmali. Mais chez le sujet jeune, cœur normal, contexte vagal, fait des syncopes, c'est la première étiologie à évoquer. Voilà, merci.
Okay, we are finishing. I want to say thank you to all of you for accompanying me in this session. It was a fantastic time for me. I hope that in the future we could have the opportunity to join once again, talking about other issue, any other that you would like to. And appreciate, Adama, your help. I apologize, I don't speak French. Not now. I don't know what is going to happen in the near future. Not now. But merci beaucoup. Merci beaucoup.
OK. En tout cas, c'est nous qui vous remercions. We thank you a lot, and we have a nice session today. I think with the help of Yves Jaume of Vitatron, we have a fantastic group. It was a world session. You know, you had some people from Puerto Rico, from Buenos Aires, from Argentina, and so from Sub-Saharan Africa and from Morocco. I think it was a fantastic session, and we thank you a lot, and we thank Vitatron for the support. So I will do a summary in French to summarize some important message before closing the session. Je pense qu'on a assisté à un propos extrêmement important sur les syncopes. C'est assez didactique. Finalement, ce qu'on peut retenir, c'est que la définition d'une syncope, c'est assez simple. C'est une perte de connaissance transitoire avec une chute. Donc, le plus souvent, on perd l'équilibre, on chute, et c'est lié à une hypoperfusion cérébrale. Et si on regarde bien, dans la définition, si on définit bien la syncope, on a à la fois le diagnostic positif, mais aussi le diagnostic différentiel, donc des autres cas de perte de connaissance qui ne sont pas d'origine syncopale. Ensuite, le principal diagnostic différentiel devant une syncope, c'est l'épilepsie, puisque syncope et épilepsie, tous les deux peuvent entraîner une perte de connaissance, tous les deux peuvent entraîner des crises tonico-cloniques, tous les deux peuvent entraîner une amnésie après la syncope. Bon, maintenant, pour faire la différence, c'est peut-être la séquence, parce que dans la syncope, c'est la perte perte de connaissance qui va entraîner une commercialité, qui va entraîner la perte de connaissance prolongée, qui va entraîner des crises tonico-cloniques, alors que dans l'épilepsie, c'est les crises tonico-cloniques qui vont se terminer par une perte de connaissance. Et donc, ça permet de faire, mais le diagnostic peut être difficile. Ensuite, il a fait la scission entre 3 types de syncopes, les syncopes vasoplégiques, les syncopes mixtes et les syncopes cardio-inhibitrices. Donc, lorsqu'on regarde ces 3 groupes-là, nosologiques, on a le mécanisme de tous les types de syncopes. Il a proposé un algorithme décisionnel avec la première étape, avec 5 points. Le premier point, c'est l'histoire de la maladie, l'examen clinique qui va passer par rechercher avec les manœuvres vagales, rechercher une hypotension orthostatique, etc. Et puis l'électrocardiogramme, la biologie et l'écho. Donc, ces 5 éléments-là, lorsqu'on les a, donc c'est des éléments accessibles, assez simples qu'on peut faire partout. Et donc, avec ça, on a le diagnostic de 50% des syncopes, le diagnostic étiologique de 50% des syncopes. Après, c'est la deuxième étape qui va regarder est-ce qu'il y a une cardiopathie ou pas. S'il y a une cardiopathie, si le CG est anormal, le plus souvent, on aura besoin de faire une exploration électrophysiologique. Si l'électrocardiogramme est pathologique, on aura besoin de faire une exploration électrophysiologique si le cœur est anormal. Si le cœur est normal, il n'y a pas de cardiopathie. Le plus souvent, on va être amené à faire un tilt test, un test d'inclinaison ou bien un holter implantable. Donc, s'il n'y a pas d'orientation étiologique et que c'est l'épisode de syncope, on peut ne pas continuer le suivi. Ce n'est pas grave, c'est peut-être quelque part réflexe et puis ça va passer. Maintenant, si c'est récurrent, là aussi, il faudra aller vers le tilt test et le test d'inclinaison. Alors, il nous a donné un score qui est extrêmement important, c'est le score de risque de mortalité, le score de OSIL. Donc, c'est un score finalement très simple. Donc, au cabinet, devant le malade, il faut regarder est-ce que le CG est normal, est-ce qu'il y a des antécédents de cardiopathie, est-ce que c'est les syncopes sans prodrome, est-ce que la personne a plus de 65 ans. Donc, si on a les 5 items-là, si on y répond, on peut classer le malade. S'il a un facteur de risque, il a 0,8% de faire un décès dans les années à venir. Maintenant, si le score est à 4, c'est 57% d'une personne sur 2 qui peuvent malheureusement se terminer par une mortalité subite. Donc, en gros, c'est ça. Après, il nous a montré quelques éléments, donc quelques exercices avec des cas cliniques extrêmement enrichissants. Donc, je pense qu'on a été pratiquement 90, une centaine de personnes à participer à cette session. Je ne sais pas s'il y a des questions brûlantes. On peut répondre à 1 ou 2 questions avant de libérer nos amis pour qu'ils vaquent à leurs occupations. Est-ce qu'il y a une question ou une remarque dans le groupe Rythmo, dans la SOSECAR ou bien le groupe du club d'anglais de la SOSECAR, enfin des DS de cardio? Question, remarque? Qui veut prendre la parole? Okay, Raul, I did a summary of the session.
Yeah,
a summary, and yes, and I asked if there is 1 or 2 short questions before closing the session. S'il n'y a pas de questions.
First of all, you talk about the difference in between epilepsy and syncope, and it's very important. One of the things that maybe many patients say is he has some contraction, hip movement when he fall down. My family, he fell down and started to move. Take into account that in epilepsy, the movement start before the patient arrives
exactly.
to the floor.
Yeah, exactly.
The patient that is in syncope for 3, 4, 5, 6 seconds probably have some movement, but it doesn't mean that it's epilepsy. Then it's very important to establish when the movement appears, before or after the patient fall down. No, after. Okay, this is not epilepsy. Yeah, this is one. Okay. And the other point that you have also remarks, of course, but the movement is sort of important when they appear. Okay.
Yeah.
You have.
Sometimes I do when I do tilt tests, when it is exactly a reflex syncope, I let the syncope going on, and after, when the syncope going on, the movement began. You know,
Yeah,
there
right.
is a tonico-clonic
Exactly.
movement, like
Right.
like
Right, exactly.
epilepsy.
Yeah, true.
Mam Awa, s'il n'y a pas de questions, je pense qu'on peut valablement remercier nos autres en bon anglais. Moi, j'ai un anglais de toute couleur, quoi, comme Abdul. Mais Abdul Karim, il est fort en anglais, il est plus fort que moi, quand même, en anglais. Mais si on peut remercier nos autres et puis clore la session, avant que Sonia ne fasse la clôture de la session. Merci.
D'accord. Merci, Professor. Thank you, Professor. Thank you, everyone, for participating to this session. Thank you especially to Dr. Raul GARILLO for being with us this afternoon. It was a really brilliant session. It was really interesting, and I think we have learned a few things this afternoon. So thank you a lot, and we are really looking forward to seeing you again, to having you again with us. Thanks to everyone, and I wish you all a wonderful evening.
My pleasure.
Yeah.
Thank you so much.
Thank
you to all of you. Thank you.
Sonia,
Ok.
Sonia will close.
Ok, merci beaucoup pour votre participation. Donc, juste vous informer que la prochaine session aura lieu dans un mois, donc le 5 août, le jeudi. Donc, c'est toujours le jeudi, 5 août. Et elle va porter sur la fibrillation atriale, sur la classification, les techniques d'ablation ou le traitement anti-arythmique. Donc, on vous invite déjà d'avance à enregistrer cette date et vous aurez des rappels en temps voulu pour que nous soyons aussi nombreux pour la prochaine session. Merci beaucoup.
Merci beaucoup. Thank you very much, everybody. Bye.
Bye. Thank you. Bye.
Goodbye, everyone.